The follow-up is very good. You begin slowly and low. This is for cannabis. Go slowly and go low. This is my practice.
You're talking about magic here, right?
It is magic.
Yeah, yeah.
In America, they called me the wizard.
Whereby someone says, what do I want out of this experience of smoking this joint? Why am I doing this? What do I hope to achieve out of it? And once you understand and define those parameters for yourself, then you can then identify what the right ways to maximize the benefits of that experience will be and also reduce the harm.
It's Reefer Madness, the podcast with Trevor and Kirk.
Kirk, we're back.
Hey, Trevor, how's it going?
Good. Let's see if we can do this up front. I'm Trevor Schufelt. I'm the pharmacist.
I'm Kirk Nyquist. I'm the registered nurse, and we are up early in this morning because we're expecting our guest from Israel to join us during as we introduce him. So I found this gentleman through Normal. As I've told our audience in the past, I have received Normal pushed emails, and I read through them, and I send out requests, and about 20% of them get back to me. And this is a gentleman that got back to me about, 3 months ago, and we've been sort of hitting back and forth, finding a time, and here it is. We're going to find time to talk to him, and I'm quite excited about it.
Yeah. So he will do a much better job, but just let's prep the people a little bit ahead of time. So, diabetic neuropathy. Tell us the real quick Cole's Nose version of what it is, and then we'll talk about what he's trying to do about it.
I have seen this condition often in my clinical practice. It's defined as damage done to the peripheral nervous system and part of the central nervous system, but it's mostly the peripheral. And what happens is that you lose sensation to the periphery, your toes, your feet, your hands, and you get pain because of that. There's a pain that comes, but there's also a loss of sensation that comes. So it's very often that diabetics will get foot ulcers or sores on their feet due to poor fitting shoes or for whatever reason, because their body has lost that fine sensitivity due to diabetes.
Yeah,
and they get pain because of it.
And like you said, that, and it can just hurt no matter what you're doing. Like they talk about in the study, allodynia, which is, even you rub a feather on your toe, hand, whatever, and your body goes, ow. And, they talk about sciatic-like shooting pains. So it can be, aside from the obvious bad part about diabetic ulcers and not feeling, it can just hurt like a lot.
Yeah.
And they put sort of...
And Dr. Robinson has just joined us. Hello, sir.
Perfect. Let's let him do that part.
We were just introducing you. As I said to you, we have our recorder on, sir. So good morning for us. How are you?
I'm fine, thank you.
Could you please introduce yourself, sir, and let us know where you are?
My name is Dror Robinson. I'm an orthopedic surgeon working in Israel at the Rabin Medical Center in central Israel.
Fantastic. I was just telling Trevor that I found your study through Normal, which is a magazine, an online magazine pushed from America. And I was trying to get a hold of you to talk about your study using inhaled cannabis to relieve people of their neuropathies.
Yes, it's a small, relatively small one-center study that just got published like in the last few months. And it is a 5-year follow-up study, which is the longest I am aware of in the literature. So most studies are like 6 weeks, 6 months, maybe 1 year, but this is a long-term follow-up study. And our results are quite interesting. First of all, the normal cohort that you follow with diabetes will worsen over time. The best drugs around can lower hemoglobin, glycated hemoglobin by 2 percentage points or 2.5 percentage points. That's the best. And actually cannabis achieves this. So this is kind of amazing. Also, it goes a little bit against the notion that cannabis worsens diabetes control. So there are a couple of studies showing that recreational cannabis users are actually worse off regarding diabetes than people who do not use cannabis. But there is at least one large study that came from the University of Nebraska and Harvard showing quite amazingly that current marijuana use is associated with lower levels of fasting insulin, lower HOMA-IR, and smaller waist circumference. So this is a very important clue. It kind of shows you that cannabis is not a glucose lowering agent, but rather a metabolic intervening agent, changing the body metabolism.
That's very curious. So you're saying part of your results, you saw that your participants had lower sugar levels, and you're saying this is marijuana, cannabis had an effect on that?
Yes, cannabis actually lowers the blood spikes, the glucose blood spikes, and this goes against the basic notion, what we call the munches, that people like to eat sugary stuff when they are using cannabis. Despite this munch or these cravings, people actually become better metabolically balanced when they are using cannabis. This is a very distinct result of our study. It can be explained partially by the effect of what is called THCV, like victory, because THCV is known to decrease insulin resistance and known to improve insulin sensitivity in animal studies.
Is that one of the reasons why you removed medical cannabis users from this particular study? You're studying, talking about cannabis and diabetes I'd like to get deeper into that. The study we got a hold of you for has to do with the pain management of neuropathies. And I noticed that when you did your sample, you removed people that were on medical cannabis. Is that because because of this effect cannabis has on the homeostasis of sugar, I guess?
Yes, we have a fairly small group, which is only 52 patients, because we were selective. We did not take anybody who used recreational cannabis. So this actually removed a lot of people, because a lot of people actually try recreational cannabis. But the advantage is that you really can show the effect, because these people had diabetes before the study. They still have diabetes, but they are improved. So you can show that the cannabis is what did the effect.
That's why I pushed out to you. One of the observations I made in your study is that you were saying that the sample had A1Cs of 9.8, which from my practice seems a little low for someone that has chronic diabetes. Did you notice a decrease in the A1C over the 5-year time you were with these individuals? Did you notice that by average everyone's A1C was lower?
Yeah, it decreased about 2 percentage points from 9 something to 7 something. This is very amazing, because in a typical diabetic cohort, you follow for 5 years, no matter what intervention, you expect to see worsening.
Yeah.
People get worse, not better.
Yeah.
So this is a very profound metabolic effect of cannabis.
Yeah, that's very much my experience. That's what startled me about your study, is that not only did people get pain relief from the cannabis, but they also had, I don't know what the word, a regulation of their diabetes as well. It appeared from the small sample.
Yes, actually, diabetes is affected in a positive manner by cannabis. I think a lot of larger RCTs are needed to show what part of cannabis does the trick. We are also only using inhaled cannabis. I'm well aware of the negative image of a doctor that recommends his patients to smoke. It sounds horrible, but I think cannabis through the lungs acts very differently than cannabis which is taken orally or in another manner. And I think it's might be a more neural effect or a different pain perception effect that actually improves the diabetes. And you do not see it with edibles or with oils or any of the oral stuff.
Dr. Robinson, Trevor, the other half, can we just talk about the pain over the 5 years for your patients? We know in neuropathy for diabetes, it's painful. You know, the current batch of medicine that we usually use only gets rid of pain about 50% of the time. We know they've got a bunch of side effects. Over the 5 years, when people added on inhaled cannabis in your study for these 52 patients, what happened to their pain?
Actually, the decrease in pain is like from about 9 at the beginning to about 2 at the end of the study. So we see a very strong analgesic effect, and we see a major decrease in medications. So people do not require that much Lyrica or pregabalin. They do not require as much Cymbalta, duloxetine, and all the other drugs, which I think can be problematic. I think they have major side effects which are quite difficult to manage. So if you can get rid of the opiates, if you can get rid of the anticonvulsants, it makes sense.
Did you, in your study, obviously you're focusing on inhaled cannabis rather than ingesting. When you were putting the study together, why did you choose to go with the inhaled form of administration opposed to edibles?
I think Israel is mostly about inhaled cannabis, like the percentage of inhaled versus other ones is about 90% inhaled cannabis, only about 10% are oils. And I think it has to do with what kind of oils we have in Israel, because many of the oils that are used in Israel are not how I would have produced the oils. Let's put it this way. There are many ways to extract cannabis. I'm not very happy with the industrial extraction processes that are used in Israel.
Mm-hmm. We actually are I guess it was our last episode, we interviewed a gentleman from Spain, Peter Vermil, and he has a technique of removing the essence of the plant that retains the acid forms of the cannabinoids, the phenabinoids. Have you heard of Peter's extraction methods?
Yes, I have. But the issue is how much you extract and how costly it gets. It is very important to keep the acid forms. And the closer you have to a real plant, the better you are. So if you have a sophisticated technique that you can actually keep the acid forms, that's fine. But unfortunately, it's not what we get over here.
If you were to improve upon the study with hindsight, what would some of the variables you may have removed, or some of the variables you would have added?
Well, it should have been a multi-center study. This would have made it more generalizable. Also, it's, we are a binational country. We have two large populations speaking different languages. I think this study did not include very many Arabic speaking people. I think this is also very important. Otherwise, I think it's a fairly well-conducted study. Of course, you need a control group, but actually, we are talking about real-time, real-world data. Real-world data, we do know what happens to diabetics without cannabis. So we are quite sure we do have the control of all the other people who do not use cannabis. So, of course, for the scientific part, you would really want to have a control group. But for the ethical part, I'm not sure it's even ethical not to offer cannabis to people with severe diabetic pain.
That's a very curious comment. I was going to ask about your sample. The sample came in; they were non-cannabis users. You asked them to use cannabis as part of the study, and now that the study's over, have these individuals continued using cannabis? And also, did you notice if there was a creep in use? Did they use more cannabis as time went on? Did they need more cannabis? Did they need a break? During the 5-year period, did they need to take a 2-week break from cannabis and then come back to it? Can you talk about their use of cannabis?
Yes, actually, they start according to regulation with about 20 grams of inhaled cannabis per month. It's about 0.6 gram per day. And actually, it's only 10% THC at this stage. And only by the end of the first year, they start getting the 20 plus THC percentage. And usually by that time, they are using about 20 to 30 grams per month. So it means about 1 gram per day of inhaled cannabis. Still, because everybody is inhaling differently, you don't really have a dosage. So you don't really know how much is actually absorbed. You only know how much is consumed. You don't know how much people are getting inside their body. But the creep is not very high. Like the people ended up with about 45 grams after 5 years. So there is a creep, but it's not very fast. You don't need to go, in most cases, to very high dosages. We are currently working on a study with almost 1,000 patients that we started using cannabis on with low back pain, which is another pain entity, quite common. So we have many more patients. And this is like a 10-year follow-up study. And I can tell you that most people do not creep much higher than 60 grams, which is about 2 grams per day. You only have a small percentage that actually need more, and you have about 5 to 10% that still need opiates and cannabis. Now, we did some studies to try to understand the demographics. Who are these people? Because they are a minority, and maybe they are not typical, and you can sort of demographically prognosticate them, like with some demographic data. You can say at the beginning what the chances are that like after 5 years, the guy is going to use 90 or 100 grams per month, which is a large dose, like it's 3 to 4 grams a day. So you can actually, we are trying to develop an index that is going to assist the doctor, like give you the chances of the guy becoming heavy user. Again, I'm not sure what heavy user means. Is it really derogatory? It sounds bad, oh, you are a heavy drug user. But actually, I'm not sure they're performing any worse than other people.
In the 5 years period of time, you've directed people to use inhaled cannabis, like you said earlier, is contrary to what we do in the healthcare field. Did you do any x-rays or diagnostics of any changes to lungs due to the inhalation of carbon? Do we have any diagnostic of that?
No, we don't. No, we don't.
I'd be curious. I also asked you about any space. in some of the people we've talked to, they have said that using cannabis medicinally, and in this sense, you've used people, this is medicinal cannabis that you're providing, that they find it that if they take a 2-week space every year or whatever they do, they find they have the cannabis has a better effect. Have you done any studies or heard of anything in that way, taking a cannabis gap?
Now we are in a regulatory loophole because you cannot really stop a license in Israel, because once you stop it, you have to start from the beginning. You cannot repeat the dose that the guy last used.
Okay.
Actually, when you are talking, just off the record and without any written evidence in the electronic files, most people will tell you that they stop occasionally. For example, when they go abroad to a country that does not allow cannabis, they would stop. And this will improve the tolerance. So people are becoming less tolerant of cannabis, and they are probably lowering the dose. But as long as cannabis is regulated, as it is in our country, it's a problem. It's a problem to actually, manage the prescription. I do not give the prescription I would like to give, okay? I would love to have THCV, like Victory, rich strains. We have excellent genetics in Israel, but there is no way to market them because actually everybody is looking at the percentage of THC. So nobody will buy a heavy THCV strain. So this is like a crazy market.
What are the laws in Israel then? In the sense, medicinally, obviously, is there recreational cannabis in Israel?
Officially not. Unofficially, of course.
Okay, fair enough. Yeah. Yes. Okay, but obviously medicinal cannabis is allowed because there's a lot of studies that come out of Israel.
Yes, medicinal cannabis is allowed. There are several indications. The most common indication is pain or chronic pain. The second most common indication is PTSD, like post-traumatic stress disorder. And unfortunately, there are indications that you are not even allowed to study. For example, schizophrenia. Is cannabis bad for schizophrenic or is it good for schizophrenic? This is tricky because once you speak with schizophrenic individuals, many of them are finding solace and less hallucinations with cannabis. So this is a very tricky point. Of course, there is a cannabis-related psychosis, no doubt. You can cause a psychosis with cannabis. But actually, many bipolar, many schizoaffective, and many schizophrenics are using, in an unofficial way, cannabis and are benefiting. So really, it's a matter that because of the regulation, the level of research is not as good as we would like it to be.
I was interested in the whole plant medicine. I actually went back to some of the literature that you cite for your study and found it interesting that one of the pieces was plant-derived medicines for neuropathies in comprehensive review and clinical evidence. I guess asking you a political question about cannabis, why do you think, with all the observational long studies we've seen, the anecdotal notes that clients give us, we know as cannabis researchers, we know that cannabis works, and we know that cannabis, the evidence is that cannabis is helping people. Why do you think Western medicine ignores it?
I think like RFK, the current head of the health ministry in the US is saying, it's the pharma industry. Once cannabis could be patented or some cannabis derivative could be patented, I'm quite sure that attitudes will change. But I think there is a difference. Even opiates are not as good as the whole plant. Like opium is not as dangerous, like the extracted milk of the poppy flower is not as dangerous as fentanyl, but it cannot be patented. So opium is a criminal offense, but fentanyl is a drug that you can prescribe. But I'm quite sure, especially in your southerly neighbor, there are a lot of fentanyl deaths. It's a dangerous.
There's a lot of deaths in Canada. It's actually a huge concern in Canada, and we've done interviews with people that are using cannabis to decrease those deaths, and it's really still tough to get that out to leadership. There's one more question I just noticed on my notes here about you're using inhalation of cannabis. Is it whole flower you're using? And are people accessing the flower themselves, or are you providing them the flower?
No, it's illegal to provide them the flower.
Right.
They have to go through pharmacy, and the flowers are really wrapped in very nice and colorful packages, but you cannot actually see what you are buying. So this gives it like a surprise bag appearance. You open it and you never know what you find inside. This is a very not natural way of selling cannabis. Cannabis should have been sold. We are in the Middle East. It's nice to go to the bazaar and buy cannabis, and then you can see what you are buying, because the smell makes a difference. The shape of the flower, the color of the flower, they all interact and they all cause part of the effect. The effect is not only by THC. It's many components acting together.
So they're obtaining their medicine, their flower, from a pharmacy. I was just very recently in Spain, and Spain is selling cannabis at storefronts, but they're selling hemp products that have been dusted with THCO and THCPs, which are derived cannabinoids from hemp. So I guess in a roundabout way, are you ensuring people are getting marijuana products, or are they getting hemp products for your study when they go to the pharmacy and they get the pretty colors? Because in Spain, it's all nicely pretty colors, and there's a bud, but inside it's not marijuana per se, it's a derived hemp product. So when your clients are getting their medicine, is it marijuana product?
Yes, everything is, in Israel, everything is not hemp. Hemp actually cannot be grown in Israel. So it's only THC, which is derived from the marijuana plant.
Wow.
And in Israel, we really believe in what's called the entourage effect. So we try to be as close to the natural flower as you can.
Okay. But the flower that their clients are getting, has it been analyzed to say 10% THC? Is it so they know they're getting? No. Okay.
Sure. Like everything is analyzed, but unfortunately, only 3 cannabinoids are analyzed. It's THC, CBD, and CBN.
Okay.
CBN is the tricky one because it's a little bit like aging of wine.
Yeah.
More CBN makes the effect of THC mellower. So a lot of the people are actually aging their cannabis. You age it for a few months and you get a better result.
Mm-hmm. Yeah, we refer to it as curing. Curing. Do people grow their own cannabis? Are any of your sample using their own medicine?
No, it's not allowed in Israel. Everything has to pass through a farm. And on the one hand, it's a little bit like medication. So there is a lot of regulation and a lot of checking and a lot of diagnostic being made. So you know there are no fertilizers and there are no anything dangerous being sprayed on the plants. Everything is tested. On the other hand, we don't have the ability to grow our own, which I would love to have, but we don't.
Very cool. Trevor?
No, I'm. Thank you for hitting on the. I thought it was interesting when I read the study that, unlike a quote unquote regular study, you didn't have really good control over what was in the cannabis. We can't say I think you had like 20% THC, less than 1% CBD, but other than that, you didn't know the strain, you didn't know how much THCV, like Victor, was in there, and yet you still got these good results over 5 years. It was interesting that there wasn't, like you said, closer to real world. We didn't have as close a monitoring of it was in the cannabis, but we still got the good results over 5 years. I thought that was fascinating.
Okay. Yes, I think a lot of it is many strains of cannabis are working. And actually, there is a very strong social networking of patients. And if you are growing or importing something which is not good, people will know about it very fast through the social network. So the good or the effective strains are being sold very fast. Once you see something is not being sold very fast, you have to doubt if it's good. And actually, there was at least one company that had a very bad crops, which was not effective. I'm not sure why, but it was not. And simply nobody would buy their products. And they stopped selling them. They're actually out of business now. But so it's not all about the THC. It's a little bit about how you grow the plant, which is tricky. It's a tricky plant, and you have to know how to grow it.
Is there any other message about your study you would like our listeners to understand?
Well, first of all, I think it's important that diabetic people will know that this is an option. This is a therapeutic option. I'm not sure how many doctors in Canada and the US actually offer it, and I think it should be offered. I think you should look at the retention rate. We have a 96% retention rate. It is unusual for people to come back. Actually, I work like in a private clinic. People actually pay for seeing me. So 96% retention is a lot. So people will not be retained unless it works for them.
It's Reefer Madness, the podcast.
So tell me, what came to your mind?
Well, first, because, and it was, I enjoyed the conversation, don't get me wrong, but just because it was a conversation, I'm going to do a quick recap of the study, jump in if I missed something. So he had 52 patients, and like you said, the amazing part about that is followed over 5 years. A 5-year study is a long time. Good, that's a good thing. So they had diabetic neuropathy, they had diabetes, they all had, he went through all the comorbidities, they all had heart conditions or peripheral vascular disease or people with diabetes leads to other stuff. And they all had some of that. Their average age about 45, mostly male. Okay, so, but they had pain. They had neuropathies. I don't want to say post-neuralgic, but no. They had diabetes nerve pain. We'll call it diabetes nerve pain, neuropathies. And what they had over the 5 years is their pain control got better. Like you said, on the 10-point scale, it went from 9 down to like 2-ish. So pain control better.
That's amazing, really. That's amazing.
That is amazing because as we sort of glossed over, the current stuff that you get from my pharmacy, the anticonvulsants like gabapentin or the like duloxetine, which is an antidepressant, or opioids, they work. but only in half-ish of people with neuropathies. Neuropathies are hard to treat. And so the fact that pain got better, and also when you think about over 5 years, you would expect sort of in general, if you did nothing, the pain get worse. That's just what we would expect. So that's good. The one that kind of blew my mind, so I'm glad you spent a little bit of time with them, is their A1Cs got better.
Yes.
So for the non-medical people, A1C, we like to think about it being sort of a 3-month average of your blood pressure. It isn't. It's measuring literally how much sugar is stuck onto red blood cells, but think about it being like a 3-month average of your blood sugar, of your blood glucose. And that got better, which is, again, that's literally what we give people diabetes medications for, is to make their blood. So the fact that cannabis made the A1C, this 3-month average of blood sugar, get better is stunning. And the last, and maybe not unexpected from the other things we saw, is they use less opioids. They use less of the other medications too, but one of the ones we worry the most about is opioids, because too much of it, people die. It has a high addiction potential, and. So better pain control, lower A1C, and less opioids. So those were the 3 big outcomes. Now we have to talk about some of the problems. We'll call it problems in quotes. It was a very small study, 52 people, not that much. Only 1 center. So again, in a perfect world, you have this done in multiple clinics over ideally multiple countries, but at least multiple parts of Israel. And it didn't have a control arm, like there was no placebo arm. So that's I'll talk about why some of those matter or not matter, but that's kind of a summary of the study, so people just sort of get back in their heads what we were talking about. Kirk, what were you thinking? And then I'll talk more.
Well, I'll use the word limitations opposed to problems. When you're looking at the study, it's the limitations of the study. But however, what I liked about the study, and I dug deep into this. Like I said, I started reading some of the papers that referred to as part of the study's reason for existing. And what I found fascinating was, and he said it, is this was real world. I mean, this is putting a situation together where you grab a sample of people and you obviously create a sample so that you have a measurable group of people to follow. And so then you give them this prescription to say, we want you to consume X amount of cannabis your way. And we know one of the biggest issues that the Western medicine has is that the client, the patient, is controlling the medication. This is not the doctor or the pharmacist saying, take X medicine 3 times a day at this quantities, and then we'll titrate it or whatever we'll do. This is the patient, real world, taking control of the medicine, and in the process of 97% following this criteria over a 5-year period, here's the result. So
I was just jumping quick on that just because, if you read studies, there's always X number of people dropped out for whatever reason.
Oh, yeah.
So they started with 52 people, they ended with 50, because 2 died.
Yes.
You start with diabetics, average age 45, follow them over 5 years. Sorry, having 2 die is not unexpected. So I would say really this was a study that had damn near 100% follow through over 5 years. 2 people didn't make it to the end of the 5 years.
So that's my observation. When I read the study, and then now talking to him, I see a real world presentation of cannabis assisting people with a chronic disease that is costing them and society billions of dollars. So, my God, once again, cannabis decreases the use of other pharmaceuticals and gives somebody better homeostasis, which is what the endocannabinoid system is all about. So I see a real world study, and the problems, the limitations, I believe, actually make this study stronger. Yeah, we could have a more diverse group. Sure, we could. But really, when it comes right down to it, I guess the only limitation I have is I'd like to know if there's any checks X-rays to see if the inhaled flower is causing systemic problems with lungs. I guess that would be my concern. But other than that, I think it's a brilliant study.
No, it really was. And I'm glad you hit on the inhaled. Most of the time when we talk about medical cannabis, it's an oral because it just is. Well, a bunch of reasons. It was interesting. This was predominantly inhaled, all inhaled because
all inhaled
because main reason he claimed is that predominantly in Israel people inhale their cannabis. That's just the way it is, which is fine. I think that would be harder in North America. It is harder to inhale stuff, be it cigarettes or vapes or cannabis. Like, for example, if I had diabetic neuralgia, I'm a pharmacist, it's minus 30 outside, I'd have to go to the other side of the parking lot to inhale my medicine in the middle of the day. I don't want to do that. So I'm not saying, but practically in North America, they're inhaling stuff is not popular. So and it was also interesting along those lines. So I'm all over the place, but interesting that it was inhaled. I don't know how we'd move that to how well that moved to North America, but I did think it was interesting that he thinks pain control with inhaled, at least from his experience, was good and or better than oral.
Well,
true, not true. I think even he would agree. We have to look into that more, but it was just interesting. That was what came out of his study.
Well, I guess the way I look at it clinically, and that's the question I forgot to ask him is, but I think he answered the question, how would you apply it clinically? I think you have to remember that from the perspective of administration, inhaled cannabis is for breakout pain, right? If I was using cannabis strictly for pain, which I have actually, I have ingested a cookie that gives me 8 hours of less pain, and if I find that I go and do something, I move my shoulders in a certain way, I'll go and have a hoot, and I get breakout pain. So I guess in some ways, in the clinically using cannabis, inhaled cannabis for me would be breakout pain because it's immediate.
Right, but that's not what he said. He said, because he said it would come in work right away, which is your breakout pain, which everybody understands, gets in fast through the lungs, lasts about 2 hours, and his opinion, learned due to the study, was the inhaled was better at pain control than oral. So that's good. That's interesting. You go, okay, everyone will do inhaled all the time. I'm just thinking ahead. I think that would be difficult in North America.
Well, it'd be interesting if he was able to get x-rays of a few of those people to see if there's any effects. I mean, after consuming cannabis for 5 years, you would assume there'd be some effect on the small bronchi. I know there would be if you're consuming tobacco products and inhaled them deep, because, they do talk about the inhaled cannabis goes deeper than the inhaled tobacco, but I don't know, I've seen some people smoke tobacco pretty deeply. Anyways, I really enjoyed this conversation. I'm so glad that he decided to join us, and I again, another gentleman to keep on my storyboard.
Absolutely. No, this was a great one. Thank you for finding Dr. Robinson, and Dr. Robinson, thank you for agreeing to talk to us. I guess, again, I've been Trevor Schufelt, the pharmacist. You are?
I'm Kirk Nyquist. I'm the registered nurse, and we are Reefer Madness, the podcast. And in the last several episodes, we have been in an international podcast, getting some cool stories from around the world. reefermed.ca. We have a blog page. We have everything transcribed. We have all the research. This paper will be attached to this episode's page. You find us on Spotify. You find us on iTunes. You find us all over the web. And if you like us, please give us a 5-star rating. Push us on to friends.
Yep, it's been another good one. Kirk, thank you very much.
Let your diabetic friends know that this episode is compelling to them. And if you have any questions or stories, just send them to us. Trevor?
No, sorry. Completely unrelated. My wife came in the door behind me, so I was distracted for a second. Sorry. Keep going.